Uh, Hello friends, good afternoon. Welcome to the anatomy session. I think next 3.5 days we'll be seeing lot of things related to the various parts of the anatomy. Okay, so we will be discussing about lot of concepts in it. Okay, we'll be good afternoon everyone. Yeah, Muga, Yadav, good afternoon. Yes, so we'll be seeing about lot of important topics in this 3.5 days. Maybe we may not be able to cover the entire nook and corner of anatomy, but the high yield areas, the important areas which where the questions comes frequently, sure we will be able to cover all this in the next 3.5 days. Okay, so we'll be starting the session with the upper limb, and yes, we all know in the upper limb the very important and high yield area is the nerves. Okay, so we'll be seeing about the nerves first, and side by side we'll be seeing about the muscles related to those nerves, and we'll be seeing about the areas of the upper limb. Okay, so with this we'll go to the topic. So the first thing we are going to discuss in the afternoon is brachial plexus. Okay, so before going into brachial plexus, guys, I want you to learn few basics in the nervous system. See, you all know that if you take the spinal cord has got the following structure like this. Okay, I hope you know the spinal cord has got two enlargements. Okay, the two enlargements are, one is called as the cervical enlargement, another one is called as the lumbar enlargement. Okay, I hope you know that there are two enlargements in the spinal cord. One is called as the cervical enlargement, another one is called as the lumbar enlargement, and then the spinal cord finally ends in a tapering end, forming conus medullaris. So this is conus medullaris. Now what I am going to do is I am going to make a cross section of the spinal cord in the cervical region. Okay, when I make a cross section of the spinal cord in the cervical region, okay, so I can able to see structure like this. So we can see the spinal cord structure like this. I hope you guys know what is the structure basically when you make a cross section of the spinal cord. So this is how the cross section of spinal cord will appear, and inside the spinal cord you will have gray matter which is in the form of a letter H shaped. Okay, so this is the H shaped form of gray matter which is inside, and in the center you have the central canal. So if you look into the spinal cord cross section, what you see here is the gray matter. Okay, so this is the gray matter. Okay, and what you see outside is the white matter. You all know this is very simple. Okay, this is very basic. We are seeing this from the school days. So you got gray matter inside the spinal cord and white matter outside. Okay, so when you take the gray matter, okay, from the gray matter you can see certain nerves which are coming out. Okay, so this is the anterior part of the spinal cord or the ventral part of the spinal cord. This ventral part of the spinal cord or the anterior part of the spinal cord is motor in nature. What is this? This is motor in nature, guys. This is motor in nature. Fine. So this motor nucleus which are present in the gray matter will give rise to the motor root of the spinal. Now this is the motor root. Okay, this is the motor root. On the dorsal side, if you go to the dorsal side or the posterior aspect, or to the dorsal aspect or to the posterior aspect of the spinal cord, you have a ganglion outside the spinal cord, guys. You have got a ganglion outside the spinal cord, and that ganglion is called as the dorsal root ganglion. So what is that ganglion called as? That ganglion is called as dorsal root ganglion. Imagine, guys, so this is a ganglion. Okay, so if you take the ganglion, within the ganglion you will have a neuron, and this neuron has got two kinds of processes. One is the central processes. So you got two kinds of processes. Okay, one is the central process, another one is the peripheral process. So what do you mean by central process? The part of the nerve which is entering the spinal cord is the central process, and the part of the nerve which is going towards the end organ is the peripheral process. So if you take the dorsal root ganglion which is present on the posterior aspect, which is basically a sensory one, okay, so it has got two processes. One is the central process which is entering the spinal cord, another one is the peripheral process which is going towards the end organ. Okay, now if you see, this is the sensory root. Okay, so this is the sensory root. This is the sensory root. Now these two roots, okay, join to form, okay, so these two roots join to form what? They form the spinal nerve. Okay, so they form the spinal nerve. So this is the spinal nerve. So if you take a spinal nerve, okay, what it is a mixture of motor and sensory. So it is usually a mixed nerve. Okay, so when you take a spinal nerve, it is a mixture of motor and sensory. Now if you see this spinal nerve, the spinal nerve divides into two branches. One is called as the dorsal rami, another one is called as the ventral rami. So this is the dorsal rami, this is the dorsal rami, and what is this? This is the ventral rami, and this is the ventral rami. Okay, so if you see the formation of a spinal nerve has got two roots. One is the motor root, another one is the sensory root, and if you see the sensory root arises from a ganglion called as dorsal root ganglion. It arises from a ganglion called as dorsal root ganglion, guys. Okay, so this is the dorsal root ganglion we are seeing. So this is DRG, dorsal root ganglion, and you can see the sensory root coming from the dorsal root ganglion. They form the nerve which is called as a spinal nerve. Okay, they form a nerve called as which is called as spinal nerve. Let us assume I have taken a section at the level of C5. Okay, so this spinal nerve, what is coming out is C5 spinal nerve. So this will be C5 spinal nerve, and this C5 spinal nerve has got a ventral rami and has got a dorsal rami. Okay, can you able to understand? So I have made a section at the level of C5. When I make a section at the C5, I can able to see a nerve which is coming out, which is nothing but the C5 spinal nerve. This C5 spinal nerve divides into dorsal rami, which goes to the posterior aspect of your body, and the ventral rami, which comes to the limbs, Okay, so that is the ventral rami of C5. Now what I'm going to do is I'm going to make a section slightly below, guys. Okay, so if you take a section here, I have done a section at the level of cervical. I'm going to make a section at the level of upper thoracic level. So I'm just going to make a section at the level of upper thoracic level. Let it be T1. I'm going to make a section at the level of T1, guys. So let us see what is happening in T1. So if you make a section at the level of T1, I can able to see the white matter very similar to the cervical region. Okay, I can able to see the white matter very similar to the cervical region. In addition to the white matter, the gray matter here presents a slight elevation on the lateral aspect. Okay, it presents a slight elevation on the lateral aspect, guys. Okay, so I can able to see the elevation, guys. Okay, what is the difference between these two sections? Yes, if you see these two sections, you don't have any elevation on the lateral side, but here when I make a section at the level of T1, you have an elevation on the lateral side. Okay, this elevation is a lateral horn of the spinal cord. This is the lateral gray horn. So what is this? This is the lateral gray horn. Normally we have got anterior gray horn and we have got posterior gray horn. In addition to that, you have got lateral gray horn. So this is lateral gray horn. This lateral gray horn you can see from T1 to L2 level of the spinal cord. Very, very important, guys. So please remember, you will see the lateral horn in the spinal cord from T1 to L2 level. Okay, and what is this lateral horn is doing? This lateral horn gives rise to the nerves of the sympathetic system. This lateral horn here gives rise to the nerves of the sympathetic system. So if some fibers are coming out here, these fibers are the sympathetic fibers, guys. These fibers are what? These fibers are sympathetic fibers. So the spinal nerve which is coming from the level of T1 will carry sympathetic fibers along with it. So okay, so if you see, if the motor root is coming here, this motor root will also carry what fibers? It will also carry the sympathetic fibers. These are preganglionic sympathetic fibers. So if I make a section at the level of T1, the spinal nerve which is coming out will have this fibers. This is called the sympathetic fibers. I hope you understood. See, this is very, very basic in understanding the brachial plexus. Okay, so you might have been thinking why I am talking about all these things now when we starting brachial plexus. If you want to understand brachial plexus, guys, or any plexus in the body, you should know this basics. Okay, so what you see here is a cross section of the spinal cord with a spinal nerve containing only the motor root and the sensory root. If I make a section of the spinal cord at the level of T1 or from T1 to L2 level, I can able to see another root coming along with it. And what is that root? That root is nothing but the sympathetic fibers coming along with the motor root, which is coming along with the motor root, guys. Okay, so with this basic, we'll go to the brachial plexus, guys. We'll go to the brachial plexus. Now, how brachial plexus is formed? Yes, brachial plexus. What do you mean by brachium, guys? What do you mean by brachium? Okay, so what do you mean by brachium? Brachium means the arm. Okay, so the plexus which goes to the arm are called as the brachial plexus. Brachium means arm. So the plexus which goes to the arm are called as brachial plexus. And how these brachial plexus are formed? The brachial plexus are formed by the ventral rami. It is formed by the ventral rami of spinal nerves from C5 to T1, guys, from C5 to T1. I hope you are clear now. Okay, so how it is formed? Ventral rami, guys. Okay, so when the spinal nerve comes out of the spinal cord, it divides into ventral rami and it divides into dorsal rami. I told you dorsal rami goes to the muscles at the back. Okay, around the spinal cord you got muscles, around the spine you got muscles. So this dorsal rami will go and supply the muscles in the paravertebral region, guys. So the ventral rami will come to the limbs now. So the ventral rami of the spinal nerve C5 to T1 gives rise to the brachial plexus, guys, gives rise to the brachial plexus. Now sometimes what happens is, apart from these nerve roots, okay, sometimes C4 may get involved in the formation of brachial plexus. So when C4 gets involved in the formation of brachial plexus, then it is called as prefixed brachial plexus. Then it is called as what? Prefixed brachial plexus. Okay, it is called as prefixed brachial plexus. If sometimes T2 get involved in the formation of brachial plexus, then it is called as post-fixed brachial plexus. Then it is called as post-fixed brachial plexus. So normally the roots which forms the brachial plexus are C5, C6, C7, C8 and T1. But sometimes a root from above might participate in the formation of brachial plexus. In that case, the T1 will become very small. So such a brachial plexus is called as prefixed brachial plexus. Or sometimes what happens is C5 becomes smaller and T2 get involved in the formation of brachial plexus, then it is called as post-fixed brachial plexus. So these are certain varieties of brachial plexus. So one is called as prefixed, another one is called as post-fixed. But when you take the formation of brachial plexus, the main roots which are involved are the C5, C6, C7, C8 and T1, guys. Okay, fine. These are the roots of the brachial plexus. Okay, these are the roots of the brachial plexus. Now what happens to these roots? These roots join. The C5 root and the C6 roots join to form the upper trunk. The C8 and the T1 root joins to form the lower trunk. The C7 does not join with anyone, it simply forms a middle trunk. Now you have got 3 trunks, okay, from the 5 roots. Okay, how it is formed? The C5 and C6 joins to form the upper trunk. UT stands for upper trunk, guys. It is upper trunk. And C8 and T1 joins to form the lower trunk. It forms the lower trunk. Okay, so the C7 continues as the middle trunk, and each of this trunk, guys, each of this trunk divides into 2. These are called as division, guys. These are called as divisions. Okay, these are called as divisions. And how many divisions are there for each trunk? Each trunk it has got 2 divisions. One is called as an anterior division, another one is called as an posterior division. So similarly, you got anterior and posterior division in all the trunks, so you got anterior and posterior division in all the trunks. Now what happens to these divisions, guys? These divisions join to form the cords. Okay, so the anterior division, okay, of the upper trunk, okay, the anterior division of the upper trunk and the anterior division of the middle trunk joins to form a cord called as a lateral cord. Okay, so joins to form a cord called as a lateral cord. So this is called as lateral cord. So the anterior division of the upper trunk and the middle trunk joins to form the lateral cord. So guys, very simple. If you see the upper trunk, the root value for the upper trunk is C5 and C6. The root value for the middle trunk is C7. So what will be the root value for lateral cord of brachial plexus? It is very simple. It is in front of your eyes, guys. It is formed by the fusion of anterior division of the upper trunk and the middle trunk. So the lateral cord will have the root value C5, C6 and C7. The nerves which arises from the lateral cord will have only these root values, C5, C6 and C7. Okay, now coming to the formation of medial cord, guys. How medial cord is formed? Medial cord is formed by the anterior division of the lower trunk, guys. Medial cord is formed by the anterior division of the lower trunk. How lower trunk is formed? Lower trunk is formed by the fusion of C8 and T1. So medial cord root value will be C8 and T1. So the nerves which are arising from the medial cord will have the root value C8 and T1, guys. Now what happens to the posterior division? All the posterior divisions, all the other posterior divisions, okay, join to form the posterior cord of brachial plexus. So posterior cord of brachial plexus will have all the root values. Okay, so it will have all the root values as from C5 to T1. It has got all the root values, guys. Okay, it has got all the root values. So if you take the cords of the brachial plexus, it has got 3 cords: lateral cord, medial cord and the posterior cord. Now how you say this is lateral cord and how you say this is medial cord and posterior cord? It is all based on the relationship with an artery. So if you take an artery which is present here, one cord is on the medial side, one cord is on the lateral side and one cord is on the posterior side. So based on the relationship with an artery, these cords are called as lateral cord, medial cord and posterior cord. And what is that artery? This artery is nothing but the axillary artery, guys. This is nothing but the axillary artery. Okay, this is nothing but the axillary artery. Okay, okay, clear, guys? Okay, fine. So this is about the formation of brachial plexus, guys. How brachial plexus is formed. So we have seen how brachial plexus is formed. Okay, so to just have a small revision, roots of brachial plexus, yes guys, it is formed between C5 to T1, guys. Okay, it is formed between C5 to T1. And how the upper trunk of brachial plexus is formed? Upper trunk of brachial plexus is formed by C5 and C6 root. middle trunk is formed by C7 root, and the lower trunk is formed by C8 and T1 root. Okay, so divisions, each of the trunk divides into 2 divisions. Yes, you know that. Okay, so I am not going into the divisions. So what is the chord? How the chord is formed? Chord is formed by the lateral chord is formed by the fusion of anterior division of okay, lateral chord is formed by the anterior division of the upper trunk, and from the middle trunk, guys, yes, medial chord is formed by the anterior division of the lower trunk, and the posterior chord is formed by the posterior division. It is formed by the posterior division of all the trunks. It is formed by the posterior division of the all the trunks. Okay, so this is how the brachial plexus is formed. Now there is a classification, or there is a division in which the brachial plexus is divided into 2 big halves. Okay, one is called as the supraclavicular part, another one is called as the infraclavicular part. This question had come in the exams, which is the supraclavicular part and which is the infraclavicular part. So now if I place a bone called as clavicle here, if I place a bone called as clavicle here, okay, exactly over the divisions, okay, so this is clavicle, okay, this is clavicle. So whatever parts above the clavicle are called as the supraclavicular part, and whatever parts below the clavicle are called as the infraclavicular parts, and whatever parts which are behind the clavicle are called as the retroclavicular part. So if I divide the brachial plexus, I can also classify the brachial plexus like this. So I can also classify the brachial plexus into supraclavicular part, okay. Supraclavicular part includes the roots and the trunks, okay. The retroclavicular part involves the divisions, and the infraclavicular part, involves the cords and the branches, okay guys, fine. So you divide the brachial plexus based on their relationship with the clavicle. Some part is above the clavicle, it is called as a supraclavicular part, and some part is behind the clavicle, that is called as a retroclavicular part, and some part is inferior to the clavicle or below the clavicle, that is called as the infraclavicular part. And we have seen what are those parts of the brachial plexus. So with this background, we will move to the branches from the brachial plexus. What are the branches which are arising from the brachial plexus? This is again a very important topic. Lot of nerves comes in this, but we will easily study this. Okay, the first is the branches from the root. If you see the root of the brachial plexus, guys, okay, if you see the root of the brachial plexus, okay, if you see the root of the brachial plexus from the C5 root, okay, from the C5 root you get a nerve which is called as the dorsal scapular nerve. So there is a nerve which arises from the C5 root, that is called as dorsal scapular nerve. Okay, and from the C5, C6 and C7, okay, so from C5, C6 and C7 you get another nerve which is called as a nerve to serratus anterior, guys, nerve to serratus anterior. Okay, nerve to serratus anterior. This nerve to serratus anterior is also called as nerve of Bell. It is also called as nerve of Bell. It is also called as long thoracic nerve. It is also called as what? It is also called as long thoracic nerve, guys. Okay, so from the C5, C6 and C7 you got an important nerve. This nerve is called as nerve to serratus anterior, which is also called as nerve of Bell, also called as long thoracic nerve. Okay, also from the C5 you get contribution to nerve called as phrenic nerve, guys. You get a contribution to phrenic nerve. Okay, what is called as phrenic nerve? Phrenic nerve is the one which supplies the diaphragm. Okay, phrenic nerve is the one which supplies diaphragm, guys. Okay, so phrenic nerve supplies diaphragm. And what is the root value for phrenic nerve? Anybody? Yes, root value for phrenic nerve is C5, C3 and C4. Okay, so it is C3, C4 and C5. So of the phrenic nerve, the C5 root is contributed by the brachial plexus. So these are the important divisions or branches from the roots of the brachial plexus. So what are we seeing? So these are the roots. So from the roots you have got dorsal scapular nerve, long thoracic nerve, and a contribution to the phrenic nerve. There are some contributions to the muscles of the neck region. There is not much needed here. So we'll go to the branches from the root. So from the dorsal scapular nerve, what is this root value? Root value is C5. And what is this dorsal scapular nerve supplying? Dorsal scapular, scapula is behind, just behind the scapula it is going, so it is called as dorsal scapular, and it supplies the following muscles. It supplies the levator scapulae, it supplies the rhomboides minor, and it also supplies the rhomboides major muscle. It also supplies the rhomboides major muscle. Rhomboides minor and rhomboides major are called as the retractors of the scapula. So if you are going to take your two scapula close together, it is called as retraction of the scapula. So rhomboides major and minor are called as the retractors of scapula. Okay guys, it is called as retractors of the scapula. Okay, so scapula can move forward, it is called as protraction of the scapula, like punching action. When you punch, the scapula moves forward, so that is called as protraction of the scapula. When you take the two scapulas towards one another, it is called as retraction of the scapula. It is called as retraction of the scapula. And levator scapulae helps in elevation of the scapula. It helps in elevation of the scapula. It helps in elevation of the scapula, guys. Okay, so dorsal scapula now supplies these muscles, and the root value for dorsal scapula is C5. Okay, fine. So where do they arise from? It arises from the roots of the brachial plexus. It arises from the roots of the brachial plexus. Now long thoracic nerve, as I already told you, it is also called as nerve of Bell. It has got root value C5, C6 and C7, guys. It has got root value C5, C6 and C7. Long thoracic nerve, as the name suggests, okay, it runs a long course in the thoracic region and it supplies a big muscle there, which is called as the serratus anterior muscle. So what is the muscle which is supplied by it? So the muscle which is supplied by the long thoracic nerve is serratus anterior. Serratus anterior. Okay, what is the action of serratus anterior? Serratus anterior helps in protraction of the scapula. Okay, protraction of the scapula. It helps in protraction of the scapula, guys. It helps in protraction, and also one more important, it helps in overhead abduction. It helps in overhead abduction of the shoulder joint. It helps in overhead abduction of the shoulder joint, guys. This is two important action of serratus anterior muscle. So serratus anterior muscle 1, it helps in protraction of the scapula, like when you are going to do a punching action, a boxing action, that is why it is called as boxer's muscle. Serratus anterior causes protraction of the scapula by that means, and it also helps in overhead abduction along with another muscle. Okay, so the another muscle which helps in overhead abduction of the scapula is trapezius muscle, guys. It is trapezius muscle. Okay, so clear. So long thoracic nerve is also called as nerve of Bell, also called as nerve to serratus anterior, that supplies the serratus anterior muscle, and we have seen the action of the serratus anterior muscle. Okay, so apart from this, so from the root we have got contribution to phrenic nerve, guys. We have got contribution to phrenic nerve, guys. Okay, we have got contribution to phrenic nerve. So the C5 root of phrenic nerve, C5 root of phrenic nerve is derived from brachial plexus, Okay, so we'll just move to the branches from the trunk, guys. Okay, so you have got three trunks. I hope you know there is an upper trunk, there is a middle trunk, and there is a lower trunk. When you take these three trunks, okay, the middle trunk and the lower trunk does not give any branches, guys. So don't worry about these two trunks. The only trunk that gives rise to branches are the upper trunk, okay, and it gives rise to two branches. One is called as nerve to subclavius. Nerve to subclavius has got root value C5 and C6. Because upper trunk root value is C5 and C6, nerve to subclavius supplies subclavius muscle. It supplies subclavius muscle, and what is the function of subclavius muscle? It steadies the clavicle. It makes a clavicle stable, nothing much. It steadies the clavicle. Okay, it steadies the clavicle. Okay, and this nerve has got one more important contribution. From the nerve to subclavius, the C5 root can form a nerve called as accessory phrenic nerve. Okay, form a nerve called as accessory phrenic nerve. This accessory phrenic nerve again supplies the diaphragm. Sometimes in a condition called as phrenic avulsion. Okay, there is an avulsion injury called as phrenic avulsion injury. Phrenic avulsion injury means the phrenic nerve gets avulsed from the diaphragm. When the phrenic nerve gets avulsed from the diaphragm, the patient will have breathing difficulty because the diaphragm is not working. If such a patient has got this accessory phrenic nerve, which is coming from the C5 root of nerve to subclavius, the patient can still able to breathe comfortably because this accessory phrenic nerve will supply the diaphragm. Can you able to understand, guys? So this is very, very important in this junction. Though nerve to subclavius is not much important to the subclavius muscle because subclavius function is very less, it has got another important role here. It gives C5 root. The C5 root goes and forms a nerve called as accessory phrenic nerve. It forms a nerve called as accessory phrenic nerve. So this accessory phrenic nerve supplies the diaphragm, guys. It supplies the diaphragm. So in the case of phrenic avulsion, this will help you in breathing. Okay, so this is about nerve to subclavius. Now next nerve from the trunk is the suprascapular nerve. C5 and C6 root value is for the suprascapular nerve again. This suprascapular nerve, after arising from the upper trunk of brachial plexus, passes through a notch called as suprascapular notch, and it passes beneath the ligament called as transversscapular ligament. Okay, so I hope you know there is a ligament in the scapula. I will just show you a small drawing here. So this is the scapula, this is the superior border of the scapula. The superior border of the scapula has got a notch. This notch is called as a suprascapular notch. Then you got the glenoid and you got the lateral border of the scapula. So, okay, so this process which you see here is the acromion and the spinous process. Now what is this, guys? What is this notch called as? Anybody? Yes, this is called as a suprascapular notch. This is called as suprascapular notch. Okay, and this suprascapular notch is bridged by a ligament. What is this ligament called as? This ligament, anybody? Yes, this ligament is called as transverse. This ligament is called as transverse scapular ligament. This is called as transverse scapular ligament. And what is running beneath the transverse scapular ligament? The nerve which runs beneath the transverse scapular ligament is the suprascapular nerve. Is the suprascapular nerve. Okay, this nerve supplies the muscle and the supraspinous fossa, and it comes and supplies the muscle in the infraspinous fossa. So it supplies two muscles here. Now what are the two muscles which are supplied by the suprascapular nerve? One is the supraspinatus muscle. One is the supraspinatus muscle, and another one is the infraspinatus muscle. Another one is the infraspinatus muscle. Okay, the supraspinatus muscle is an initiator of abduction of the shoulder joint. So it helps in abduction of shoulder joint. It helps in abduction of the shoulder joint. ABD. ABD stands for abduction of the shoulder joint. And infraspinatus helps in external rotation of the shoulder joint. Infraspinatus helps in external rotation of the shoulder joint. Okay, so these are the action of these muscle, guys. Okay, so from the trunk, what trunk? From the upper trunk you have got two branches, guys. Okay, so from the upper trunk you have got two branches. One is called as nerve to subclavius, another one is called as suprascapular nerve. Both have got the same root value, C5 and C6. Nerve to subclavius supplies subclavius muscle, suprascapular supplies two muscles. One is the supraspinatus muscle, another one is the infraspinatus muscle. Supraspinatus muscle is an abductor. So if you are going to do abduction of the shoulder joint, the initial 15 degree of abduction is caused by the supraspinatus muscle and the external rotation of the shoulder joint. So this is external rotation of the shoulder joint. This external rotation is also caused by this muscle called as infraspinatus muscle. Both are supplied by suprascapular nerve. So these are the branches from the trunk, guys. So we have done with the branches from the root and from the trunk of the brachial plexus, guys. Okay, from the root and the trunk of the brachial plexus. With this we'll move to the next branches, that is branches from the cords. You can ask me, sir, you have missed one thing in between, that is divisions. No branches from the divisions. Yes, no branches arises from the divisions. So from the brachial plexus, trunk, root, okay, and the cords gives branches. Division does not gives any branches. So the branches arising from the cords are, first is lateral cord. Lateral cord, you can keep a mnemonic, guys, easy to remember. Okay, so one mnemonic is Lata loves music. Okay, Lata Mangeshkar, I hope you know Lata Mangeshkar, a famous singer. So that is Lata loves music. Okay, Lata loves music. We keep it like this, LLM, Lata loves music, and M stands for musculocutaneous nerve here. Okay, the musculocutaneous nerve here, it has got root value C5, C6 and C7, guys. It has got root value C5, C6, C7. Lateral pectoral nerve, okay, that is also got the same root value, and lateral root of median nerve is present here. That has also got the root value C5, C6 and C7, guys. Okay, so when you take the branches from the lateral cord of brachial plexus, if you keep this mnemonic, it will be easy for you to remember. So one is called as lateral pectoral nerve. Next is called as lateral root of median nerve, and next one is called as a musculocutaneous nerve. If you take these, musculocutaneous nerve is one of the important branch, and the lateral root of median nerve, which is going to form the median nerve, is again an important branch here, guys. Again an important branch here, guys. Okay, so what we are discussing is the branches from the cords. Okay, the first one is the lateral cord of brachial plexus. Okay, so from the lateral cord of brachial plexus, we have got these three nerves. Okay, one is musculocutaneous nerve, lateral pectoral nerve, and next one is lateral root of median nerve. Okay, now coming to the next branches, the branches from the medial cord of brachial plexus. Okay, so you have got lot of nerves in this. Very easy way to remember is, okay, so more, you can keep this mnemonic, more money makes men unhappy. More money makes men unhappy. Okay, this is a very important statement, guys. Okay, so if you run behind money, okay, you'll 100% you'll become unhappy. Okay, so you do your profession, you do your job, or you do it happily, and money will follow you. Okay, so this is a statement for every man here. So more money makes men unhappy. The first M, let us consider, this is medial pectoral nerve. Next M stands for medial cutaneous nerve of the arm. The next M stands for medial cutaneous nerve of the forearm, and the next M stands for the medial root of the median nerve, and the last one is the ulnar nerve. U stands for ulnar nerve. Okay, so you got medial pectoral nerve, medial cutaneous nerve of the arm, medial cutaneous nerve of the forearm, medial root of the median nerve, and the ulnar nerve. So these are the 5 branches from the medial cord of the brachial plexus, guys. Okay, so the last cord which we are going to see here is the posterior cord of brachial plexus. So from the posterior cord of brachial plexus, you got again 5 branches, which you can remember by this mnemonic as ultra. Okay, you can remember this by ultra, or you can remember it by this mnemonic as ulnar. Anything you can keep. Both this will hold good for the posterior cord of brachial plexus. So what are the nerves which are arising from the posterior cord of brachial plexus? U stands for upper subscapular nerve here, upper subscapular, and L stands for lower subscapular nerve, and N stands for nerve to latissimus dorsi. Okay, or it is also called as thoracodorsal nerve, guys. So it is also called as what? Nerve to latissimus dorsi is also called as thoracodorsal nerve. It is also called as thoracodorsal nerve. Okay, it is also called as thoracodorsal nerve. And the important nerve here is the axillary nerve, and the last nerve, that is R, stands for radial nerve. Okay, R stands for radial nerve. So you got upper subscapular, lower subscapular nerves. Okay, these upper subscapular nerve supplies the subscapularis muscle. Okay, it supplies the subscapularis muscle. The lower subscapular nerve supplies the subscapularis. Okay, it supplies the subscapularis muscle along with teres major muscle, guys. It supplies teres major muscle. Nerve to latissimus dorsi supplies, as the name suggests, it supplies the latissimus dorsi muscle. Axillary nerve supplies deltoid muscle. Okay, it supplies deltoid muscle, and it also supplies teres minor. It also supplies teres minor. Okay, and radial nerve supplies all the muscles of the posterior compartment of the arm and the forearm, guys. Okay, so you got lot of muscles in the posterior compartment of the forearm, and you got triceps here in the posterior compartment of the arm. So those muscles are supplied by the radial nerve. We will see about radial nerve, median nerve, and ulnar nerve in detail when we come to the subsequent topics. So that is why I am not telling about those nerves here. So just have an idea that these are the branches from the cords of the brachial plexus. So easy way to remember is by keeping the mnemonics. Okay, fine. So with this we'll go to the next part of the brachial plexus, that is the brachial plexus injuries. Okay, so before going into the brachial plexus injuries, just a small refresher here. Okay, so you have a branch called as medial cutaneous nerve. Can anybody tell me medial cutaneous nerve is a branch of? Yes, medial cutaneous nerve is a branch of what part of the brachial plexus, guys? Medial cutaneous nerve is a branch of, it is a branch of the medial cord of brachial plexus. It is a medial cord of brachial plexus, gives rise to the medial cutaneous nerve of the arm. Yes, and the medial cutaneous nerve of forearm is a branch of, yes, it is again the same. It is again arising from the medial cord of the brachial plexus. Yes, upper lateral cutaneous nerve of the arm is a branch of. We haven't discussed about this. We'll discuss that in detail or in a short while. Okay, so upper lateral cutaneous nerve of the arm is a branch of axillary nerve, guys. It is a branch of axillary nerve. It is a branch of axillary nerve. Lower lateral cutaneous nerve of the arm is a branch of radial nerve. It is a branch of radial nerve. We'll discuss all this nerve, guys, so don't worry about it. This is just a refresher to compare the medial cutaneous nerve with the lateral cutaneous nerve with the of the forearm and the arms. Okay, so don't worry about it. Posterior cutaneous nerve of the arm. Okay, these are not branches of the cords, but these are all branches of the nerve roots specifically. So posterior cutaneous nerve of arm is a branch of. Okay, posterior cutaneous nerve of arm is a branch of, guys. Yes, it is a branch of radial nerve, guys. Yes, it is a branch of radial nerve. Posterior cutaneous nerve of forearm is again a branch of radial nerve. Is again a branch of radial nerve. Now comes the twist. Lateral cutaneous nerve of forearm is a branch of lateral. See, if you see here, medial cutaneous nerve of forearm is a branch of what? It is a branch of medial cord of brachial plexus, whereas lateral cutaneous nerve of forearm is a branch of. Okay, so the lateral side of the forearm is supplied by musculocutaneous nerve. It is supplied by musculocutaneous nerve. It is a branch of musculocutaneous nerve. It is a branch of musculocutaneous nerve. Okay, fine. Okay, so with this we are done with the parts of the brachial plexus. Okay, now we are going slowly into the injuries to the nerves and injuries to the brachial plexus. So we'll just see an important basics again here. Okay, see, if you take a nerve, let us consider this nerve. You will know that this section right from your school days. Okay, so you have a multipolar neuron like this. So multipolar neuron will have a cell body, you will have a nucleus, it will have multiple dendrites here. I'm not going into the parts of the typical neuron. I hope you know this is a multipolar neuron. This has got a cell body and this has got an axon here. Now this axon is surrounded by a sheath called as myelin sheath. Okay, so this is surrounded by a sheath called as what? This is surrounded by a sheath called as myelin sheath. Yes, anybody? Myelin sheath is formed by what are the cell that forms the myelin sheath, guys? Yes, yes, I am waiting for your reply, guys. What is the cell that contributes to the formation of myelin sheath? Yes, so the myelin sheath is formed by a cell called as Schwann cells. Okay, it is formed by a cell called as Schwann cells in the peripheral nervous system. This is the one which forms the myelin sheath. Yes, very good, Anashwara. Yes, very good. So what is the cell that contributes to the formation of myelin sheath in the central nervous system? This is peripheral nervous system. In the central nervous system, can anybody tell me what is the? Yes, very good, it is oligodendrocyte. It is oligodendrocyte. Excellent. So okay, so what is the difference between these two cells? What is the difference between Schwann cell and oligodendrocyte? Oligodendrocyte and Schwann cells. If you take Schwann cell, one axon is covered by multiple Schwann cells. Okay, multiple Schwann cells, whereas here one oligodendrocyte can cover multiple nerves, can myelinate multiple nerves, that is the difference between these two. So in Schwann cells, usually if you take axon, multiple Schwann cells covers a single axon, but when you take the oligodendrocytes, one oligodendrocyte can myelinate multiple axons. That is the difference between these two. One is present in the peripheral nervous system and another is present in the central nervous system, guys. Now if you take this axon per se, okay, this entire axon is covered by an outer covering like this, and this outer covering of the axon is called as the endoneurium. Okay, endoneurium. Now several axons joins to form a nerve bundle and several nerve bundles joins to form a nerve. So when I make a section of the nerve, okay, I am just making a section of the nerve, guys. So if I make a section of the nerve, inside the nerve, this is an histology of nerve. So when you make a section of the nerve, you see certain things like this. So you see the axons here. These axons are surrounded by myelin sheath. Yes, I am not drawing the myelin sheath. This is an axon with the myelin sheath I am drawing, and each of these axons are surrounded by an outer covering called as endoneurium. So this is what this blue color represents the endoneurium here. You can see several axons are combined with one another, and these several axons which are combined with one another forms a nerve bundle or a nerve fascicle. Okay, so the collection of axons forms a nerve bundle or nerve fascicles, and the entire nerve fascicle is surrounded by an covering called as perineurium. Okay, so what is this? The covering which is seen here is called as the endoneurium. And what is this? The covering which you see here, the covering of the nerve fascicle is called as perineurium. This is called as perineurium. And what is the outermost covering of the entire nerve called as? This is called as epineurium. Okay, this is called as epineurium. So you have got three coverings here. One is called as the endoneurium, which surrounds the axons. Then this is the perineurium, which surrounds the entire nerve bundle, and the entire nerve is surrounded by epineurium. So we got three coverings here, guys. Okay, need three coverings. Now whenever a nerve is going for an injury, okay, a nerve can go in for three types of injuries. Okay, so nerve injuries, if you take nerve injuries, okay, so there is a person called as Seddon who put forward a classification called as Seddon's classification. Okay, so he classified the nerve injuries into three types, guys. What are the three types? One is called as neuropraxia. Okay, next one is called as axonotmesis, and last one is called as neurotmesis. Okay, one is called as axonotmesis, another one is called as neurotmesis, another one is called as neuropraxia. Now what does this nerve classification tells us? See, neuropraxia means there is no discontinuity in the axons or no discontinuity in the nerve. So there is only physiological stretching, no anatomical disruption has happened. No anatomical disruption has happened. Okay, no anatomical discontinuity. Okay, very very important guys. No anatomical discontinuity. Only there is an physiological disruption of the nerve transmission. Only there is a physiological disruption of nerve transmission. Okay, nerve transmission, there is only physiological disruption of nerve transmission whenever there is a neuropraxia kind of injury where there is no anatomical discontinuity and only there is a physiological disruption. This kind of nerve injuries will recover very well, okay. So there is an 100% recovery in this. There is an 100% recovery in this. Okay, so there is no problem with neuropraxia. It will recover well because there is no anatomical discontinuity. Now what happens to axonotmesis? Suppose if you see here, okay, if only the axon is cut here, okay, so if only the axon is cut, the remaining part of the outer coverings, okay, they are intact. This kind of injury is called as axonotmesis. Okay, what do you mean by axonotmesis? Only axon is cut guys. The surrounding tubes, namely the endoneurium, perineurium and the epineurium are all intact. Okay, so only there is a cut in the axon alone, the tube is intact. Now whenever there is a cut in the axon, okay, so what is the nature of anything? So whenever there is an injury, the nature will try to heal it. Now how it will heal? It will try to form a new axon. Okay, so what happens to the older one? So the older one which are present here degenerates. Okay, so this degeneration which is happening here is called as an Wallerian degeneration. This is called as what? Wallerian degeneration. Okay, now after Wallerian degeneration happens, the nerve which is newly formed by a process called as Wallerian regeneration. This is called as Wallerian regeneration. Okay, so after axon is cut, the part distal to the cut portion dies off. That is called as Wallerian degeneration. After the distal portion dies off, the nerve newly forms. That new formation of the nerve is called as Wallerian regeneration. Now what is happening here? Since the tube is intact, since the endoneurium is intact, since the perineurium is intact, the nerve formation is very very good. It happens properly and it reaches the end organs here again. So what is happening in axonotmesis? So here axon is cut, the tubes are intact, okay. So Wallerian degeneration happens here, yes. Wallerian degeneration happens here, yes. After degeneration, Wallerian regeneration also happens. Okay, so here it forms a neuroma in continuity. Okay, so the chances of recovery is good again here. Chances of nerve recovery is good again. Here. Okay guys, clear? So whenever there is an axonotmesis type of injury, only the axon is cut, all the other tubes are intact, so the nerve can grow well within the tube and there is a high chances for this kind of injury to recover well. Okay, now whenever a patient has got an axonotmesis injury, suppose let us consider in my hand my ulnar nerve is cut at the level of elbow, maybe it's a type of axonotmesis kind of injury. Now what happens is the nerve tries to grow, isn't it or not? So at what rate the nerve tries to grow? The nerve tries to grow at a rate of 1 mm per day. Okay, so the nerve tries to grow at a rate of 1 mm per day. So for every day the nerve will grow 1 mm. Now what I do is I try to tap the nerve. Okay, the point where the nerves are growing, you will have a tingling sensation. And what is that sign called as? Yes, anybody, what is that sign called as? A growing nerve. If you tap along the course of the growing nerve, you will have a tingling sensation. And what is that sign called as? Anybody? Yes, I'm waiting for the answer guys. Yes, so yes Vinitha, it is called as Tinel sign. Very good, it is called as Tinel sign. So this is called as Tinel sign. So in axonotmesis you will get Tinel sign. And what is this Tinel sign will be? One day you get Tinel sign here, since the nerve is growing. After 1 month you will get Tinel sign more distally. After 1 month you get Tinel sign more distally. So here the Tinel sign is progressing. So this is called as what? This is called as progressive tinal sign. This is called as what? This is called as progressive tinal sign. This is very, very important for nerve recovery. If you see a progressive tinal sign, that means the nerve is recovering, the nerve is growing well. So that is called as an progressive tinal sign. Okay, so in an axonotmesis you have all this finding, guys. You will have all these findings. You will have the Wallerian degeneration, you will have Wallerian regeneration, you will have the neuroma in continuity, and you will also have a progressive tinal sign. Now what happens to neurotmesis? Here the entire nerve gets cut. Okay, here all the tubes are cut. Okay, all the tubes are cut. So just imagine when all the tubes are cut. Okay, so when all the tubes are cut here, I'll just show you what happens here. When the tubes are cut, okay, when the tubes are cut, okay, when the tubes are cut, the axon doesn't know where to go. There is Wallerian regeneration happening, but the axon doesn't know where to go. So it goes in an haphazard manner and it forms a neuroma. This neuroma is an end neuroma. So this is an end neuroma. Okay, so this is an end neuroma. So in neurotmesis, okay, there is a formation of end neuroma. Okay, since there is an end neuroma formation, the nerve is not progressing, that the nerve is not growing. So when the nerve is not growing, the tinal sign is not progressive. So there is a non-progressive tinal sign. There is a non-progressive tinal sign. There is a non-progressive tinal sign. So when you have this kind of injury, it requires nerve repair. It requires nerve repair. You cannot wait and watch. Okay, you cannot wait and watch. You have to repair the nerve. There are various ways to repair the nerve, by doing an end-to-end repair, by doing a grafting. Okay, I'm not going into the details, that will take our topic way far away from anatomy. So just to understand that there are three types of nerve injury. One is called as neuropraxia, next one is called as axonotmesis, and next one is called as neurotmesis. Okay, so this kind of nerve classification is called as Siddon's classification. I'll just add only one more point here. There is another classification for nerve injury called as Sunderland classification. There is another classification called as Sunderland classification for nerve injuries. Okay, again I am not going into the details of Sunderland classification, just understand that there are two classifications for nerve injuries. One is called as Siddon's classification, another one is called as Sunderland classification, guys. Okay, so please remember, in neuropraxia 100% recovery is possible. There is no anatomical discontinuity. Okay, in axonotmesis, axon only cut, only axons are cut. Okay, the tubes are intact. So here the recovery is very good. Here the tinal sign will be in progressive tinal sign. Here the tinal sign is in progressive tinal sign, whereas when it comes to neurotmesis, the tinal sign is not progressive. Okay, very, very important point. So there is a non-progressive tinal sign because of the end neuroma formation. Because of the end neuroma formation. So any nerves in the body will go through any one of these kind of nerve injuries. Okay, we'll go through any one of this, any one of these kind of nerve injuries. Okay, so with keeping this in background, we'll go to the nerve injuries now. Okay, we'll go to the nerve injuries. So first nerve what you are going to see here is the axillary nerve. Okay, before going into the axillary nerve injury, we'll just trace where the axillary nerve is and where it is going. Okay, so suppose if you consider this as the shoulder joint. Okay, so this is the humerus head. This is the greater tuberosity of the humerus. This is the shaft of the humerus. This is the shaft of the humerus, and this is the lesser tuberosity of the humerus. Okay, so what is this? This is the greater tubercle of the humerus. This is called as the greater tubercle of the humerus, and this is called as the lesser tubercle of the humerus. This is called as the lesser tubercle of the humerus. Okay, guys. Now from the greater tubercle, you get a ridge which is called as the intertubercular ridge. This is the lateral lip of the intertubercular ridge. This is called as the lateral lip of the intertubercular sulcus, and this is called as the medial lip of the intertubercular sulcus. This is the medial lip of the intertubercular sulcus. So this is intertubercular sulcus. Okay, so these are the parts in the proximal part of the humerus. So humerus has got a head. Okay, this is the head of the humerus, and you got the greater tubercle, lesser tubercle, and you got the sulcus here. Okay, guys. So what is this head of the humerus articulating with? This head of the humerus articulates with a cavity called as glenoid cavity, and this glenoid cavity is a part of what? This is a part of the scapula. This is a part of scapula. I hope you know that. And you see a hook-like projection in front of the scapula. If you see a hook-like projection in front of the scapula, this process is called as the coracoid process. What is this process called as? This is called as the coracoid process. Guys, always remember, when you see coracoid process, that is the anterior aspect of the anterior aspect of the scapula. When you see the spinous process, that is the posterior aspect of the scapula, that is the post aspect. So here you see coracoid process, so that must be an anterior aspect of the scapula. Okay guys, clear? Now when you see this from the anterior aspect of the scapula, there is a fossa called as subscapularis fossa. From the subscapularis fossa you get a huge muscle. Okay, this muscle is called a subscapularis muscle. It goes and gets inserted into the lesser tubercle. So this is the insertion of the subscapularis muscle. So what is this? This is the insertion of the subscapularis muscle. So subscapularis muscle arises from the subscapular fossa. Okay, so what is this fossa called as? Anybody? Yes, what is this fossa? This fossa is called as subscapular fossae. So from the subscapular fossa you have the subscapularis muscle arising, and this subscapularis muscle arising, and it is where it is going and get inserted. It is getting inserted into the lesser tubercle. It is going and getting inserted into the lesser tubercle. Okay guys, clear? So subscapularis muscle is on the anterior aspect of the scapula, and it goes and gets attached to the lesser tubercle of the humerus. Okay, so this muscle is anterior to the shoulder joint. This muscle is anterior to the shoulder joint. And if you see the lateral border of the scapula, there is an interesting muscle which is coming from the lower part of the lateral border of the scapula. This is called a teres major muscle. So this teres major muscle goes and gets attached to the medial lip of the intertubercular sulcus. So okay, what is this lip? This lip is called as the medial lip of intertubercular sulcus. Now what is this muscle called as? This muscle is called as the teres major muscle. Okay, this is called as teres major muscle guys. This is called as teres major muscle. So what is this muscle? The muscle which arises from the lateral border of the scapula and going and getting inserted into the medial lip of the intertubercular sulcus is called as a teres major muscle. Is called as teres major muscle. Now you get a glenoid tubercle here. Okay, so you get a cavity here. So this is the glenoid cavity guys. So this is the glenoid cavity. Okay, so below the glenoid cavity you get a tubercle. This is called as the guys, I think again there is a small issue in the connectivity. We'll just stay for a minute. Yes, okay, so we are back again. So there is a tubercle here. This tubercle is called as the infraglenoid tubercle. So what is this tubercle called as guys? Yes, this tubercle is called as the infraglenoid tubercle. So this is called as infraglenoid tubercle, and from the infraglenoid tubercle you have a muscle, and the muscle which arises from the infraglenoid tubercle is called as the long head of triceps. So what is this muscle? So this muscle is called as a long head of triceps. This is called as the long head of triceps. Okay, this is called as long head of triceps. Now if you see just below the shoulder joint you get a space which is quadrangular in shape. This space is called as a quadrangular space. Now what is this space called as? This space is called as quadrangular space. In order to understand the axillary nerve, you must understand the quadrangular space, then only you can able to understand the axillary nerve very easily. Now if somebody asks you what are the boundaries of the quadrangular space, now you can easily tell the quadrangular space is bounded superiorly by subscapularis, it is bounded inferiorly by the teres major, it is bounded medially by the long head of triceps, and it is bounded laterally by the surgical neck of humerus. So what is this neck called as? This neck is called as the surgical neck of humerus. This is called as the surgical neck of humerus. This is called as the surgical neck of humerus guys. Okay, so when you take a artery which is running in this region, I hope you know what is that artery called as. This artery which is running here is nothing but the axillary artery. So what is this artery? This is called as the axillary artery. Okay, this is called as the axillary artery. Okay, so just running behind the axillary artery. Okay, running behind the axillary artery, I am just using blue color for the nerve here because yellow color will not be visible in the picture clearly, so I am using the blue color. Just behind the axillary artery you get a cord. This cord is called as a posterior cord. So what is this cord called as? This is called as a posterior cord of brachial plexus. So from the posterior cord of brachial plexus you get a nerve called as axillary nerve. This axillary nerve, after arising from the posterior cord of brachial plexus, enters this space called as quadrangular space, and in the quadrangular space it divides into two divisions. One is called as anterior division, another one is called as posterior division. So the anterior division winds around the surgical neck of humerus like this, and the posterior division goes below and supplies the muscle called as teres minor and ends in a ganglion called as an pseudoganglion. There ends in a ganglion called as pseudoganglion. So if I want to put the axillary nerve here, so the axillary nerve is passing through the quadrangular space. In the quadrangular space it divides into two divisions. One is the anterior division which is winding around the surgical neck of the humerus. You can see it is winding around the surgical neck of humerus here, and the other division runs along the lateral border of the scapula and supplies two muscles. One is the posterior fibers of the deltoid and another one is the teres minor muscle. Okay, now when the anterior division is winding around the surgical neck of humerus, it is accompanied by an artery from the third part of axillary artery. This artery is called as a posterior circumflex humeral vessels. So if somebody asks you what is this nerve which is running through the quadrangular space, okay, what you will tell? So the nerve which is running through the quadrangular space is the axillary nerve, and the artery which is accompanying the axillary nerve, is the posterior, okay, posterior circumflex humeral artery. It is the posterior circumflex humeral artery. Okay guys, clear? Very clear. So from the axillary artery, from the third part of the axillary artery, you get a branch. So that branch is called as posterior circumflex humeral artery, and this artery is accompanying which nerve? It is accompanying the anterior division of the axillary nerve. So this is an MCQ again here. What is the nerve that passes through the quadrangular space? Axillary nerve. What is the artery that accompanies the axillary nerve? That is the posterior circumflex humeral vessel. I hope the axillary nerve is clear. Now if you see here, the axillary nerve is very close to two things. One, it is close to the surgical neck of humerus. It is also just below the shoulder joint. So if any pathology around this region like shoulder dislocation or an proximal humerus fracture or an surgical neck of humerus fracture can injure the axillary nerve. Okay, so we'll go into the problems of the axillary nerve. So before that, axillary nerve, just you can make this chart. Okay, so it has got a motor supply and it has got a sensory supply. And this motor supply, it supplies mainly the deltoid muscle, and it supplies a muscle called as teres minor muscle. Sensory. Now what happens to the sensory? If you see here, the nerve, when it winds around the humerus, it gives a branch to the skin of the deltoid region, and this branch is called as the upper lateral cutaneous nerve of the arm. This is called as the upper lateral cutaneous nerve of the arm. So the sensory part here is the upper lateral cutaneous nerve of the arm. It is called as the upper lateral cutaneous nerve of the arm. And where it supplies? It supplies the deltoid region. It supplies the skin over the deltoid region. Guys. Okay, so clear. So whenever there is an axillary nerve injury, it is not only the muscles which are affected, there is a sensory branch also. And where is the sensory branch supplies? This sensory branch supplies the dorsal, the skin over the deltoid region. And what is this area called as? This area is called as the regimental batch area. So this area is called as what? This is called as a regimental batch area. So whenever there is an injury to the axillary nerve, either by means of shoulder dislocation or by means of an proximal humerus fracture, it is not only the motor part which is getting affected, it is also the sensory part which is getting affected. And which area you are going to check the sensation? Yes, you are going to check the sensation on the skin over the deltoid, and this area is called as what? This is called as a regimental batch area. This is an important finding in shoulder dislocation, because whenever there is a dislocation or whenever there is a fracture, you will not be able to lift your shoulder. You cannot check the motor part, you have to check only the sensory part. And how are you going to check the sensory part? By checking over the skin over the deltoid region. Okay guys, clear? So axillary nerve, remember, once you see axillary nerve, regimental batch area should come in your mind. What are the two muscles that are supplied by the axillary nerve? One is the deltoid, another one is the teres minor. Okay, okay, fine. So this is about the axillary nerve injury, guys. So with this, we'll go slowly into the next part of the nerve injury, that is brachial plexus palsy. Okay, brachial plexus and Klumpke's palsy, very important topic. Okay, very important topic. So if you take the brachial plexus palsy, okay, you should know what are the nerves that are affected in the brachial plexus, and usually what kind of injuries a Erb's palsy or brachial plexus palsy occurs. Okay, see, normally whenever a child is being delivered from a mother, okay, if it is in cephalic presentation, like as you see in this picture, where the child is pulled out of the mother's body by means of the head, okay, this is called as cephalic presentation. Okay, so there can be chances of increased angulation between the head and the shoulder. Okay, so the angle between the head and the shoulder increases. When the angle between the head and the shoulder is increases when you drew the child out, there is a chance for the trunk, upper trunk of the brachial plexus to get injured. So you got three trunks which are running in the neck region. One is the upper trunk, middle trunk, and the lower trunk. So when there is an increased angle between the head and the shoulder, the upper trunk can get injured. So the injury to the upper trunk of the brachial plexus is called as Erb's palsy. Is called as an Erb's palsy. Okay, is called as an Erb's palsy. Now, Erb's palsy is an injury which occurs at a point called the Erb's point, where 6 nerves meet. Now, what are the 6 nerves? You all know that C5 and C6 root joins to form the upper trunk. From the upper trunk, you get 2 nerves. One is called as the suprascapular and the nerve to subclavius. The upper trunk divides into 2 divisions, anterior division and posterior division. Now, the meeting point of this 6 nerves, okay, 1, 2, 3, 4 and 5 and 6, the meeting point of this 6 nerves is called as the Erb's point. Is called as the Erb's point. So injury to the Erb's point, okay, injury to the Erb's point, it results in a palsy called as Erb's palsy. Results in a palsy called as Erb's palsy. Okay, I hope you are clear what is called as an Erb's point. Now, if you see clearly, the roots which are affected are the root value which are involved in the Erb's palsy is C5 and C6, predominantly C5, guys, predominantly C5. So what are all the muscles or what are the nerves which carries C5 and C6? Those muscles will be worst affected in this Erb's palsy. Now we'll just break down in this and we'll see what is happening here. Okay, if you see Erb's palsy, so you know that there is a nerve called as a suprascapular nerve. You know that there is a nerve called as suprascapular nerve. Okay, so which has got a root value of C5 and C6, which is affected in brachial plexus palsy. That's affected in Erb's palsy. So whenever there is a suprascapular nerve injury, what is the function of suprascapular nerve? What does it supply? It supplies 2 muscles. Okay, it supplies 2 muscles. What are the muscles which are supplied by the suprascapular nerve? Yes, guys, the 2 muscles which are supplied by the suprascapular nerve are, one is supraspinatus. One is supraspinatus and another one is infraspinatus. Another one is infraspinatus. And can anybody tell me the action of this? Okay, the supraspinatus is supplied by, okay, the supraspinatus is the action of the supraspinatus helps in abduction of the shoulder joint. It helps in abduction of the shoulder joint. And what is the function of this infraspinatus? Infraspinatus helps in external rotation of the shoulder joint. Helps in external rotation of the shoulder joint. Okay, guys, clear? So what is the function of supraspinatus? It helps in abduction of the shoulder joint. And what is the function of the infraspinatus? It helps in external rotation of the shoulder joint. Okay, it helps in external rotation of the shoulder joint. Now, when suprascapular nerve is affected, these actions will not happen. These actions will not happen. The next nerve which has got root value of C5, C6 is axillary nerve. Is axillary nerve. Axillary nerve has got again root value C5 and C6. You all know that axillary nerve has got a muscle which is supplying, so that is deltoid, and then another muscle which is supplied by axillary nerve. Just now we saw that is teres minor. Again, both have got same action similar to the action which we saw above. Deltoid helps in abduction of the shoulder joint. Deltoid helps in abduction of the shoulder joint, and whereas teres minor helps in external rotation of the shoulder joint. Teres minor helps in external rotation of the shoulder joint, guys. Okay, clear? So axillary nerve, it has got root value of C5, C6. In brachial plexus, axillary nerve is also one which is worst affected. So when axillary nerve has got affected, so 2 actions are not possible. One is abduction of the shoulder, not possible. External rotation of the shoulder is also not possible. The next nerve which is involved in this is musculocutaneous nerve. Okay, musculocutaneous nerve. Musculocutaneous nerve, though the root value is C5, C6 and C7, the main root value is C5 and C6. Main root value is C5 and C6. So the musculocutaneous nerve supplies 3 muscles. Okay, so one is coracobrachialis. One is coracobrachialis. Okay, another one is biceps. Okay, brachialis. Another one is biceps brachii. So these are the 3 muscles which are supplied by the musculocutaneous nerve. And if you take this, coracobrachialis is supplied by C7. So in Erb's palsy, this is not affected. This is not affected. So don't worry about coracobrachialis. But biceps and brachialis has got root value C5 and C6. Okay, these muscles are worst affected. Now, can anybody tell me what is the function of the brachialis muscle? Yes, brachialis. What is the function of brachialis? Brachialis helps in flexion of the elbow joint. Brachialis helps in flexion of the elbow joint. So when brachialis is not working, flexion of the shoulder joint will not takes place. So this is the flexor of the this is the flexor of the elbow. So flexion of the elbow does not takes place. Okay, so flexion of the elbow does not takes place. And what is the function of biceps? Biceps has got two function. Again it causes flexion of the elbow. Again it causes flexion of the elbow. In addition to that, it also causes, very important, it also causes supination of the forearm. It also causes supination of the forearm. Okay, very important point, guys. So brachialis, it helps in flexion of the elbow joint, whereas biceps, it not only helps in flexion of the elbow joint, it also helps in, this is pronation, this is what, supination. Okay, so the supination action is produced by biceps. When the Erb's palsy happens, musculocutaneous nerve C5C6 roots does not work. So when C5C6 roots does not work, brachialis and biceps does not work. So just see what is happening here. You cannot do abduction of the shoulder, you cannot do external rotation of the shoulder, you cannot flex your elbow, you cannot pronate your forearm. So what is happening here? Okay, what is you cannot supinate your forearm. So what is happening here? So my shoulder goes in for adduction. Okay, my shoulder goes in for adduction, my elbow goes in for extension, and my forearm goes in for pronation, because supination is not happening. So when I have this kind of attitude, okay, this is called as what? This is called as the policeman tip deformity, or a Erb's or an Vaiter's tip deformity. Okay, so when the shoulder goes in for adduction, when the elbow goes in for extension, and the forearm goes in for pronation, you get a classical attitude like this. So this attitude is called as what? This attitude is policeman tip deformity or Vaiter's tip deformity. Okay, this is called as Vaiter's tip deformity. Okay, it is called as Vaiter's tip deformity, also called as policeman tip deformity, also called as policeman tip deformity. Guys, please remember, these kind of Erb's palsy is most commonly associated with birth injuries. Okay, so birth injuries. So that is why Erb's palsy is also called as, that is why Erb's palsy is also called as obstetric palsy. It is also called as what? Obstetric palsy. Since the child is delivered, and during the delivery time brachial plexus gets injured, so this palsy is also called as obstetric palsy, guys. Okay, so Erb's palsy is also called as obstetric palsy. And please remember, whenever there is an obstetric palsy, mostly this is an neuropraxia kind of injury. This is a neuropraxia kind of injury, and whenever there is a neuropraxia kind of injury, the chances of recovery is good. The chances of recovery is good. The chances of recovery is good. Okay, clear? So there is a classification system for Erb's palsy. Okay, so there is a classification system called as Naraka's classification. There is a classification system called as Naraka's classification, which is used to classify Erb's palsy. Okay, so guys, please remember, whenever there is an Erb's palsy, mostly it is a neuropraxia kind of injury. It will recover well. Okay, and it is classified by classification system as Naraka's classification. But sometimes if the Erb's palsy is so severe, when it is associated with an accident, like a road traffic accident, when there is an complete tear, like a neurotomesis kind of injury, then you need to repair the brachial plexus. When you repair the brachial plexus, you give a splint for the patient. So when you repair the brachial plexus, you give a splint called as aeroplane splint for the patient. So if somebody asks you, where is aeroplane splint is used? Aeroplane splint is used in the treatment of Erb's palsy. Whenever you use Erb's palsy, whenever you use aeroplane splint, you keep the shoulder in abduction, you relieve the tension over the nerve roots. So that is called as aeroplane splint, guys. That is called as aeroplane splint. Okay, so I'm not going into the details of splints. Okay, so that will become an entire different topic. So we are restricting ourselves to Erb's palsy now. Okay, so we are restricting ourselves to Erb's palsy. So these are the things which are happening in the Erb's palsy. So there is adduction and medial rotation of the shoulder joint, because abduction and external rotators are not working. Flexors are not working at the elbow joint, so the elbow is going for extension. Supinators are not working, so the forearm is going for pronation. This is a classical attitude of Erb's palsy. Okay, so I hope you understood what is called as Erb's palsy. Next is Klumpke's palsy. Klumpke's palsy or Klumpke's paralysis. If you want to understand Klumpke's paralysis, you need to understand certain basics here, guys. Okay, I'll just see a few basic thing here. Okay, So where is the sympathetic and the parasympathetic outflow comes to our body? Okay, so if you take the autonomic nervous system, the autonomic nervous system are of two types. One is called as a sympathetic type, another one is called as a parasympathetic type, another one is called as a parasympathetic type. The sympathetic origin or the sympathetic outflow in the body occurs from the thoracic level of the spinal cord and from the upper lumbar level of the spinal cord. So this sympathetic outflow is called as an thoracolumbar outflow. This is called as an thoracolumbar outflow. So if somebody asks you where does the sympathetic activity or where does the sympathetic starts first, it starts from the spinal cord from the thoracic level. So from the T1 level to L2 L3 level is the area where you can see the sympathetic origin. So this is called as an thoracolumbar outflow. Parasympathetic is, it arises from the brain and it arises from the sacral region, so it is called as an craniosacral outflow. This is called as an craniosacral outflow. Okay, so you know that the cranial nerves, okay, you know that the cranial nerves 3, 7, 9 and 10 are the parasympathetic nerves of the head and neck region. Okay, so from the head and neck region, so the cranial nerves 3, that is the oculomotor nerve, 7, that is the facial nerve, 9th, that is the glossopharyngeal nerve, and 10th is the vagus nerve, is the one which carries the parasympathetic outflow. And also from the sacral region, S3, okay, S2, S3 and S4 is the area where you can see the parasympathetic outflow in the sacral region. So the parasympathetic outflow is called as a craniosacral outflow. Sympathetic outflow is called as a thoracolumbar outflow. And if you see the T1 which is seen here is a part of the brachial plexus, is a part of the brachial plexus. What part of the brachial plexus? It is a part of the lower trunk of the brachial plexus. In Klumpke's palsy, the lower trunk of the brachial plexus is injured, and yes, the sympathetic outflow is also getting injured in the Klumpke's palsy. Okay, it is also getting injured in the Klumpke's palsy. Now you should know the two difference between the sympathetic activity in the body and the parasympathetic activity in the body. Okay, see, I'll just usually in my classes I give a simple example to understand the sympathetic activity and the parasympathetic activity. See, just imagine a dog is chasing you. Whenever a dog is chasing you, what are all the changes that happens in your body? Okay, is sympathetic activity. See, when a dog is chasing you, what happens to your heart rate? Your heart rate will increase. Okay, so your sweating will increase. Your sweating will increase. Okay, whenever a dog is running behind you, you need to see the surrounding clearly and you need to run. So if you need to see the surrounding clearly, what happens to your pupil? Pupil dilates, so you will have mydriasis. Mydriasis is dilation of the pupil, and you need to have your eyelids open. Okay, so you will have nice opened eyelids so that you can see the surrounding clearly and you can run. And whenever the dog is running behind you, your gut motility decreases. Okay, so your muscles are working very well, so your GI motility, okay, your GI motility decreases and the sphincters become active. Okay, and the sphincters are constricted Okay, so these are the things which happens whenever there is a sympathetic activity. Parasympathetic activity is very, very simple, guys. Whenever you are sleeping comfortably after having a good meal, you sleep comfortably. So what are the changes which happens in your body comes under the parasympathetic action. So when you are sleeping, it's okay, your heart rate is calm and down. Okay, you don't have much of sweating, so your sweating decreases in whenever there is a parasympathetic activity. Now you want to sleep, less amount of light should enter your eyeball, so your pupils will constrict, which is called as miosis. Your GI motility will increase. Okay, so your GI motility will increase, and whereas your sphincters will relax. Okay, so these are the things which happens whenever there is a parasympathetic activity. So whenever there is a sympathetic cut down, so opposite to the sympathetic cut down is parasympathetic. Those things will go up in the body. Now come to the Klumpke's paralysis. You will understand what is called as Klumpke's paralysis. So Klumpke's paralysis is basically an injury to the lower trunk of the brachial plexus. As I already told you, there are three trunks: the upper trunk, the middle trunk, and the lower trunk. Okay, so you got three trunks. So when the angle between the head and the shoulder increases, the upper trunk is injured. When the angle between the shoulder and the trunk increases, okay, when the angle between the shoulder and the trunk increases, like as you see in this picture. Okay, so whenever there is an hyper abduction of the shoulder, whenever there is an hyper abduction of the shoulder, whenever there is an hyper abduction of the shoulder, okay, the lower trunk of brachial plexus is injured. The lower trunk of brachial plexus is injured, and the lower trunk of brachial plexus has got root value C8 and T1, and C8 and T1 is the main root value for ulnar nerve, is also the main root value for ulnar nerve. Okay, so also the main root value for ulnar nerve. Okay, ulnar nerve root value is C8 and T1. So whenever ulnar nerve is involved, what happens, your hand function decreases, because most of the intrinsic muscles of the hand are supplied by ulnar nerve. So because when the intrinsic muscles of the hand are not working properly, intrinsic muscles of the hand are not working properly, it results in clumsiness of the hand. It results in clumsiness of the hand, and also the patient will land up in a deformity called as clawing of the hand. Results in a deformity called as clawing of the hand. We'll discuss about clawing in a short while. What is the muscle that is responsible for clawing? What happens whenever there is a clawing of the hand? But whenever there is an ulnar nerve injury, so please remember guys, so ulnar nerve supplies the small muscles of the hand. So when the small muscles of the hand are not working, fine movements of the hand will be lost. So that will result in clumsiness of the hand, and also the patient will land up in or end up in clawing of the hand, guys. So this is about the injury to the lower trunk of brachial plexus affecting the ulnar nerve. Now what happens, not only the ulnar nerve is involved, but the sympathetic outflow to the face, to the head and neck is also getting involved, because T1 is the sympathetic outflow, to the head and neck region, So when this is get off, it results in a classical syndrome called as Horner syndrome. Now what happens in the Horner syndrome, as we already discussed? So mydriasis does not happen. Okay, the pupils will constrict, so the patient will have miosis. The eyelids droops, it is called as ptosis. Okay, so the eyeball sunkens in, that is called as enophthalmos. There will be loss of ciliospinal reflex. So whenever a patient has gotten Horner syndrome, the patient will have the following findings. The patient will have drooping of eyelids, the patient will have miosis, the patient will have loss of sweating, that is called as hand hidrosis. Along with that, the patient will have a sunken eyeball, which is called as enophthalmos, because there is a muscle called as orbitalis muscle, which is supplied by sympathetic activity, which is not working. So when orbitalis muscle is not working, it results in enophthalmos. Can anybody tell me where orbitalis muscle is in? Yes, from the audience guys, anybody? Where is orbitalis muscle is in? Anybody? Orbitalis muscle is a smooth muscle which is seen in the floor of the orbit, When the tone of the orbitalis muscle is good, the eyeball will be in normal position. When the tone of the orbitalis muscle is lost, when there is an injury to the nerve supplying the orbitalis, then the tone of the orbitalis muscle is lost and the eyeball sunkens. So that is called as enophthalmos, and the patient will also have another problem, that is loss of ciliospinal reflex. Okay, loss of ciliospinal. What is ciliospinal reflex? When you pinch the neck region, the pupil dilates, that is called a ciliospinal reflex. So a patient with the ptosis, miosis and hidrosis and enophthalmos with loss of ciliospinal reflex, the diagnosis stands in front of your eyes, that is Horner syndrome. Okay, so whenever a patient has gotten clumsiness of the hand, clawing of the hand with an Horner syndrome, so the diagnosis is Klumpke's paralysis. So Klumpke's paralysis is due to involvement of the lower trunk of the brachial plexus. It is involved due to the lower trunk of the brachial plexus. That happens not only due to an hyperabduction injury. Okay, so that obtains sometimes whenever there is an injury to the axilla, can also injure the lower trunk of brachial plexus and can cause this kind of Klumpke's palsy. Okay, so this is about the clawing of the hand and the Horner syndrome seen in this picture. You can see here. So this is the clawing of the hand. Okay, so with this we'll move to the next injury. Okay, so that is the radial nerve and its injury. Okay, so radial nerve and its injury, very very important nerve. Frequent questions have come in this area. So understanding of radial nerve, understanding its course, its supply is very very important. Lot of times questions have come from this area. Okay, so we'll just go again with a simple diagram so that you can easily understand where the radial nerve is running and what are the muscles which are supplied by the radial nerve. Okay, so to understand the radial nerve, so this is again the shoulder joint. You all know that the greater tubercle is here, the shaft of humerus is here. Okay, and the shaft of the humerus, at the end it forms the lateral epicondyle, capitulum, the trochlea, the medial flange of the trochlea, and the medial epicondyle. Okay, so these are all the parts of the lower part of the humerus bone. Okay, I'm just covering the humerus bone also side by side. And what is this cavity, which is called as a glenoid cavity, which is a part of scapula bone, which is part of scapula bone, and you can see a joint which is formed here. So that joint is called as the shoulder joint. This joint is called the shoulder joint. Now I hope you know that there is a lip of intertubercular sulcus. This is the lateral lip of intertubercular sulcus, and this is the medial lip of intertubercular sulcus. Okay, now you can also see a groove on the posterior aspect of the shaft of the humerus. Okay, so what you see here is the anterior aspect of the shaft of the humerus. On the posterior aspect of the shaft of the humerus, you can see a groove. This groove which you see on the posterior aspect of the shaft of the humerus is called as a radial groove. Is called as a radial groove. So what is this groove? So this groove is called as a radial groove. Okay, this is called as a radial groove. This radial groove is also called as a spiral groove. This is also called as what? This is also called as spiral groove. Okay, I hope you are clear. So this is radial groove, which is also called as spiral groove. And I think we have seen in the previous discussion that there is a muscle which arises from the lateral border of the scapula and gets inserted into the medial lip of the intertubercular sulcus. I hope you don't have any doubt in this muscle. Yes, anybody? What is the muscle which arises from the lateral border of the scapula and getting inserted into the medial lip of the intertubercular sulcus? Yes, anybody? Guys? Yes, it is teres major. Very good, Muga. Very good. And there is a muscle which arises from the infraglenoid tubercle and it is running down, okay, to the arm. So the muscle which arises from the infraglenoid tubercle and running down to the arm is the triceps muscle. So what head of triceps is this? This is the long head of triceps. This is long head of triceps. And what is this muscle? This muscle is called as a teres major muscle. This muscle is called as a teres major muscle. Now you get a triangle in this area. This triangle is called as the lower triangular space. Now what is this triangle represents? This triangle represents the lower triangular space. Okay, so this is lower triangular space. Okay, and what are the boundaries of the lower triangular space? Yes, the lower triangular space is bounded superiorly by, it is bounded superiorly by this muscle. So this is teres major, this is teres major, and it is bounded on the medial side. Okay, it is bounded on the medial side by the long head of triceps, long head of triceps, and it is bounded laterally by, okay, it is bounded laterally by, yes, anybody? It is bounded laterally by the shaft of the humerus. It is by the shaft of the humerus. Very very important space, lower triangular space. Lower triangular space is bounded on the superior aspect or above by the teres major, and on the medial side by the long head of triceps, and on the lateral side by the shaft of the humerus. Now you know that there is an artery again which is running in the axillary region, that is the axillary artery. Just running behind the axillary artery is a nerve. Okay, that nerve or that cord is called as the posterior cord of brachial plexus. This is the posterior cord of brachial plexus. For coloring sake, I will use blue color for the nerve here. So from the posterior cord of brachial plexus you get a branch which is called as the radial nerve, So radial nerve initially runs in the axillary region. Okay, then it passes through the lower triangular space. It enters the lower triangular space, then it runs behind the humerus through the spiral groove. Okay, when it runs in the spiral groove, it is accompanied by an artery here. Can anybody tell me what is the artery which is accompanying the radial nerve in the spiral groove called as? Anybody? Yes guys, I hope you are listening. Okay, so when the radial nerve runs in the spiral groove, what is the artery that is accompanying the radial nerve in the spiral groove called as? So this artery is called as the profunda brachii artery. So this artery is called as the profunda means deep. Okay, so it is a branch of brachial artery. This is called as profunda brachii artery. So profunda brachii artery accompanies the radial nerve, and now the radial nerve runs crosses the spiral groove, reaches the lateral aspect of the arm. It reaches the lateral aspect of the arm. In the lateral aspect of the arm, you see a septum, and this septum is called as the lateral intramuscular septum. This septum is called as lateral intramuscular septum, and the nerve runs in front of the lateral intramuscular septum, and it runs in front of the lateral condyle of the humerus, Okay, this is very, very important. So the point where the nerve pierces the lateral intramuscular septum is very, very important, because the nerve is tethered in this region. The nerve is tight in this region. Okay, so any stretching in this region will affect this nerve. Okay, so please remember this nerve. This area is very, very important. So this is called as the lateral. This is called as the lateral intermuscular septum. This is called as the lateral intramuscular septum. Okay, so the radial nerve, after piercing the lateral intramuscular septum, comes to the anterior aspect of the arm, and it runs in front of the lateral condyle of the distal humerus. I hope you know that there is a fossa which is formed here. This fossa which is formed here is the cubital fossa. The fossa which is formed here is called as a cubital fossa. Okay, so this fossa is called as what? This is cubital fossa, and the nerve now enters the cubital fossa, and in the cubital fossa it divides into two branches. It divides into a superficial and deep branch. Okay, so guys, remember, radial nerve course, it arises from the posterior cord of brachial plexus. It is arising in the axillary region. It runs downwards, enters the lower triangular space, passes behind the humerus through a groove called a spiral groove. Okay, then it pierces the lateral intramuscular septum, comes to the anterior compartment of the arm, reaches the cubital fossa, divides into two branches. One is called as the superficial branch, another one is called as the deep branch. Okay, I hope you are clear. Any doubt in the course of the radial nerve? No? Okay, so if you are clear with this, okay, we'll just go and see what are the muscles supplied by the radial nerve. Okay, only when you know the muscles which are supplied by the radial nerve, you will understand the lesion that is happening because of the radial nerve. So to understand the muscles, okay, so you can see here the muscles in the back of the arm. So there are a big muscle in the back of the arm which is called as the triceps muscle, and it has got three heads. Basically it has got three heads, guys. It has got three heads. One is called as the long head, next is called as the medial head, and next is called as the lateral head of the triceps. So triceps has got three heads. One is called as the long head, next is called as the medial head, and next is called as the lateral head. Okay, all these three heads join to form a tendon, and this tendon gets inserted into a bony process called as the olecranon process. Okay, going and getting inserted into a process called as the olecranon process. Okay, so this is very, very important, guys. So all these three heads of triceps fuses and gets inserted into the olecranon process. Now when you go to the forearm, okay, okay, so in the forearm you got lot of muscles on the extensor aspect. Just to tell you what are the name of the muscles, okay, so we'll just see the muscles of the dorsum, or the posterior aspect of the forearm. Okay, muscles of the posterior aspect of the forearm are divided into two. Okay, so one is called as the superficial group, another one is called as a deep group. There are totally 12 muscles in this region. The superficial group occupies 7 muscles, and the remaining 5 muscles are in the deep group. So what are the muscles which are seen in the superficial group? Okay, so the first muscle is brachioradialis. The next muscle is extensor carpi radialis longus. The next muscle is extensor carpi radialis brevis. Okay, guys, clear? So you got three muscles which forms the lateral bulk of your forearm. These three muscles are, one is the brachioradialis, extensor carpi radialis longus, and extensor carpi radialis brevis, and these three muscles are together called as mobile vad of Henry. They are called as mobile vad of Henry. These three muscles are together called as mobile vad of Henry. Okay, they occupy predominantly the lateral aspect of the forearm. Okay, though they are called as the posterior compartment muscles, they occupy predominantly the lateral aspect of the forearm. Okay, apart from this, okay, you got unconeus, you got extensor digitorum muscle, you got extensor digitorum muscle. Okay, you got extensor carpi ulnaris muscle. Okay, you got extensor carpi ulnaris muscle, and you got extensor digiti minimi muscle. You got extensor digiti minimi muscle. These muscles forms the superficial, okay, these muscle forms the superficial group of the extensors aspect of the forearm. Now what are the deep muscles? The deep muscles, one is supinator, okay. The next muscle in this region is abductor pollicis longus. The next muscle is extensor pollicis longus and extensor pollicis brevis, and the last muscle is extensor indicis muscle. These five muscles forms the deep group of the posterior aspect of the forearm. Okay, so guys, so we are just discussing the muscles of the posterior aspect of your arm and in the forearm. In the arm you got only one muscle, it has got three heads, that is triceps. In the posterior aspect of the forearm you got 12 muscles. So these 12 muscles are divided into two groups. One is the superficial group, another one is the deep group. The superficial group contains 7 muscles in it, so we have named those muscles. Okay, so one is brachioradialis, another one is extensor carpi radialis longus, another one is extensor carpi radialis brevis, next is unconeus, extensor digitorum, extensor carpi ulnaris, and so on. Okay, and on the deep group, one is called as supinator, abductor pollicis longus, extensor pollicis longus, extensor pollicis brevis, and extensor indicis. They form the deep group. Okay, so don't worry about this. So there are, though there are number of muscles in this region, what you need to understand is only very few things. Okay, so keeping these muscles in the mind, okay, we'll just see the actions of these muscles so that you can able to understand what is happening here. Okay, if you take the triceps muscle, triceps muscle is the extensor of the elbow joint. Triceps is the extensor of the elbow joint. Okay, what is this? Triceps is the extensor of the elbow joint. Okay, next is the extensor carpi radialis longus muscle. Extensor carpi radialis longus muscle is the main extensor of the wrist joint. Okay, so other muscles, okay, other muscles are the extensors of the fingers and the thumb. Okay, so other muscles means you don't take unconeus, you don't take supinator. Other extensor muscles mainly, they are extensors of the fingers and the thumb. So you need to understand these three muscles basically. So what is triceps? Triceps helps in extension of the elbow joint. Extensor carpi radialis longus helps in extension of the wrist joint. Okay, extensor carpi radialis longus helps in extension of the wrist joint. The other extensor muscles, so don't worry about supinator, don't worry about unconeus, they have got their own actions. The other extensor muscles, they help in extension of the fingers and the thumb. Extension of the fingers and the thumb is produced by the other muscles. Okay, now when you see the radial nerve, when the radial nerve runs from the axillary region down to the elbow region, how it supplies? Okay, so the supply of the axillary nerve above the spiral groove. Okay, so you can see here spiral groove is here, just above the spiral groove. Okay, so this muscle or this nerve supplies the long head of triceps and the medial head of triceps Okay, it also gives a cutaneous branch above the level of spiral groove. Okay, so that is called as the posterior cutaneous nerve of the arm region. So these are the branches from the radial nerve above the level of spiral groove. So branches, we are discussing about the branches of the radial nerve. We are discussing about the branches of the radial nerve. So above the level of spiral groove, you get these three main branches. So two supplies muscles, one supplies the skin region of the arm. Okay, so one is the long head of triceps, which is supplied by the radial nerve. Another one is the medial head of triceps, which is supplied by the radial nerve above the level of spiral groove. This is very, very important. Okay, so please keep in mind, above the level of spiral groove, only triceps is being supplied here. Okay, next is at the level of spiral groove. At the level of spiral groove. At the level of spiral groove. Okay, so guys, very, very important. At the level of spiral groove, the lateral head of triceps, the medial head of triceps, the lateral head of triceps, the medial head of triceps. Okay, next the posterior cutaneous nerve of the forearm, next is lower lateral cutaneous nerve of the arm are all the branches which arises from the nerve at the level of spiral groove. In addition to that, unconeus muscle is also supplied when the nerve is traveling in the spiral groove. So when the radial nerve travels in the spiral groove, please remember guys, it supplies the lateral head, it supplies the medial head, and it also supplies the unconeus muscle. It also gives cutaneous branches. So one is the posterior cutaneous nerve of the forearm, another one is the lower lateral cutaneous nerve of the arm. So don't worry about those cutaneous nerves much. So please remember, above the level of spiral groove, long head and medial head. At the level of spiral groove, lateral head and medial head and unconeus muscle Now below the level of spiral groove. Okay, so below spiral groove, it supplies two muscles. One is the brachioradialis, another one is extensor carpi radialis longus. Okay, and the fourth one is the deep branch. So it enters the cubital fossa, divides into superficial branch and deep branch, and this deep branch supplies the other extensors. Okay, so please remember here, when the nerve is running in the spiral groove, okay, and above the spiral groove, it supplies the triceps mainly. When it is running below the spiral groove, it supplies the brachioradialis and extensor carpi radialis longus. And when it is becoming deep branch, this deep branch supplies the other extensors of the wrist. Okay, I hope you are clear with this. Now suppose if a lesion happens to the axillary nerve, so this is very, very important, analyzing the lesion of the axillary nerve, lesion of the radial nerve at various level. So if suppose the radial nerve gets injured below the level of elbow, at or below the level of elbow, just think guys. Okay, so lesion of the radial nerve below the elbow. Okay, one is below the elbow. When the radial nerve gets injured below the level of elbow, okay, so below the level of elbow, if you see this chart, okay, below the level of elbow is only the deep branch. So below the level of elbow is only the deep branch, which supplies the extensors of the fingers and the thumb. So what the patient will not be able to do, when the nerve is getting injured below the level of elbow, the patient will not be able to do extension of the fingers and the thumb region. It results in thumb drop and finger drop. Thumb drop plus finger drop. Okay, it results in thumb drop plus finger drop. I will just put it as TD and FD so that you can easily write in the other lesions. Okay, so when there is a lesion of the radial nerve below the level of the elbow, the patient will have difficulty in extension of the thumb and the fingers. So there will be thumb drop and the finger drop. Okay, so there will be thumb drop and finger drop. Now if the lesion is happening below the level of spiral groove, okay, so the above muscles will get affected. Okay, so the patient will have thumb drop plus finger drop. Okay, in addition to that, the patient will not have functioning of extensor carpi radialis longus. So extensor carpi radialis longus is the wrist extensor. We have seen that extensor carpi radialis longus is the wrist extensor. So I told you triceps is the elbow extensor, triceps is the elbow extensor, extensor carpi radialis longus is the wrist extensor. The other extensors are the thumb extensors and the finger extensors. So when the radial nerve get injured below the level of spiral groove, see here, below the level of spiral groove, what is the muscle that is supplied by the radial nerve? It is ECRL, that is extensor carpi radialis longus. When extensor carpi radialis longus doesn't work, it results in wrist extensor failure, so that results in wrist drop also. It results in wrist drop. Okay, so this patient will have thumb drop, this patient will have finger drop. In addition to that, this patient will also have wrist drop. Okay, and also guys, please remember, okay, the radial nerve, okay, the radial nerve divides into two branches in the cubital fossa. One is the superficial branch, another one is the deep branch. This deep branch is the motor branch. This is the deep branch, which is also the motor branch, which is also called as a posterior, interosseous nerve, which is also called as a posterior interosseous nerve. There is another branch which is running here. This is the superficial branch, and this superficial branch is purely a sensory branch. It is purely a sensory branch, and it supplies the first web space of the dorsum of the hand. It supplies the first web space of the dorsum of the hand. So whenever there is an injury above the level of elbow, okay, so there will be a sensory loss also. So this patient will also have sensory loss along with this, okay, fine. So very, very important points. So whenever there is a lesion below the level of spiral groove, the patient will have thumb drop, the patient will have finger drop, the patient will have wrist drop, and there will also be loss of sensation in the dorsum of the first web space. There will be loss of sensation in the dorsum of the first web space. So all these four findings will be seen here. Now coming to the third entity, lesion at the level of spiral groove. Lesion at the level of spiral groove. Lesion at the level of spiral groove is called as an high radial nerve palsy. And the lesion below the level of spiral groove is called as an low radial nerve palsy. Okay, it's called as an low radial nerve palsy. So one is called as an high radial nerve palsy, another one is called as an low radial nerve palsy. Okay guys, so whenever there is a lesion at the level of spiral groove, just tell me what are the muscles that are getting paralyzed now. One is the lateral head of triceps, which is not working now whenever there is an injury at the level of spiral groove. Then medial head becomes weak, okay, medial head of triceps will become weak. Then ECRL and the other finger extensors will become weak, So this patient will have the following findings. He will have weakness of elbow extension. Because his lateral head and medial head of triceps have become weak, so their lateral head is not working, medial head has become weak, so there will be weakness of elbow extension. Since all the other muscles below are getting affected, the patient will have wrist drop, the patient will have finger drop, and the patient will also have thumb drop. In addition to this, the patient will also have loss of sensation. Okay, so there will be loss of sensation over the dorsum of the first web space. Okay, clear? So all these findings will be seen when there is an injury to the radial nerve at the level of spiral groove, guys. Okay, so please be clear in this. Each levels are very important. Okay, a question will come, a patient with a high radial nerve palsy, what are all the things you will see, what are all the functions that will be lost. So there will be weakness of elbow extension along with the other drops. Okay, fine. So next is the last lesion, that is the lesion of the radial nerve. Where above the spiral groove. So whenever there is a lesion of the radial nerve above the spiral groove, we call this as an very high radial nerve palsy. Okay, this as a very high radial nerve palsy. This is called as very high radial nerve palsy. Whenever there is a lesion at this level, whenever there is a very high radial nerve palsy happens, what happens? All the muscles are affected in this. All the muscles which are supplied by radial nerve are affected in this. So the patient elbow will go into a state of flexion. Okay, the extensor have become totally weak. Completely the triceps muscle has become lost its power. So the elbow will go into a flexion attitude. So there will be flexion of the elbow. There will be flexion of the elbow. Okay, the patient will have wrist drop along with it. The patient will have thumb drop along with it. The patient will have finger drop. And the patient will also have sensory loss along with this. So whenever you see a patient with a radial nerve palsy, and if the elbow is in a state of flexion with the wrist drop, finger drop, with the loss of sensation here, the answer is very high radial nerve palsy. The answer is very high radial nerve palsy. Radial nerve palsy is very important question. Only when you understand the muscles which are supplied at various levels, you can able to understand the various lesions of the radial nerve. Okay, so if you see here, just a small recap guys, just see here, above the level of spiral groove, the long head and triceps and the medial head of triceps are supplied. At the level of spiral groove, the lateral head of triceps, the medial head of triceps and the unconeus is supplied. So triceps, it causes elbow extension, it causes elbow extension. This action you must remember, then only you can able to understand the palsies. Now below the level of spiral groove, above the level of elbow. Okay, so the lesion is below the level of spiral groove, above the level of. So whenever there is a nerve running below the level of spiral groove, it mainly supplies two muscles. One is brachioradialis, another one is extensor carpi radialis longus. And extensor carpi radialis longus is the main wrist extensor, Okay, when the nerve reaches the cubital fossa in the elbow region, it divides into two branches. One is the D branch, another one is called as the superficial branch. The D branch is also called as what? It's also called as posterior interosseous nerve. It supplies all the extensor muscles of the forearm here. Okay, and this muscles will cause thumb extension and finger extension. Okay, so finger extension and thumb extension is caused by these muscles. So if you see the lesions, so whenever there is a lesion at various level, various muscles get weak and the patient will have corresponding findings. So if you see a patient with this kind of attitude, okay, so the patient has a wrist drop, then there is an chances of radial nerve palsy. Okay, the patient has got a radial nerve palsy. So that happens very frequently in this kind of attitude. So sometimes the patient drinks in the Saturday time and they sleep over the arm, over the chair. Okay, so that kind of palsy is called as what? It is called as Saturday night palsy. Saturday night palsy. Okay, so in Saturday night palsy you got radial nerve neuropraxia. You got radial nerve neuropraxia. I hope now you understood what is called as neuropraxia. Neuropraxia means no anatomical discontinuity, just there is a compression of the nerve, physiological disruption of the nerve supply happens. That is neuropraxia. Good recovery is present. This patient will recover within 3 months of time. This patient will recover within 3 months of time. Similarly, a patient can have radial nerve palsy following an improper placing of the crutches. The patient will be given axillary crutches. So they give crutches and they walk. So when they keep the axillary crutches, when they place it over the humerus shaft, it can cause radial nerve palsy. So they are called as crutch palsy. They are called as what? Crutch palsy. So crutch palsy is also due to radial nerve injury. It is resulting in radial nerve neuropraxia. So crutch palsy, Saturday night palsy are all examples for various radial nerve lesions. Okay, fine. So I hope you understood the course of the radial nerve. Okay, two important things you should remember. One is the lower triangular space and the spiral groove. Next is the point where the nerve pierces the lateral intramuscular septum. It is very important. Now if somebody asks you what is the most common cause of radial nerve lesion, okay, so somebody asks you what is the most common cause of radial nerve lesion or most common cause of radial nerve injury, what you will say? You will say that there is a fracture which causes most commonly radial nerve injury. That fracture is called as Holstein-Lewis fracture. That is called as Holstein-Lewis fracture. Now what is called as Holstein-Lewis fracture? It is a fracture of the shaft of humerus. It is a fracture at the shaft of humerus at the junction of okay, upper 2/3 and distal 1/3. So when the shaft of humerus get fractured at the junction of upper 2/3 and distal 1/3, okay, so resulting in okay, resulting in a spike, okay, resulting in a spike, okay, resulting in a spike that is injuring the radial nerve. This kind of fracture is called as Hallstein-Lewis fracture. This kind of fracture is called as what? Hallstein-Lewis fracture. Hallstein-Lewis fracture is the most common cause. It is the most common cause. It is the most common cause of radial nerve palsy or radial nerve injury. It is the most common cause of radial nerve injury. Okay. So in this session, I think we have discussed about lot of important things. Okay, so we have been discussing about the basics of nerve formation. We have been discussing about the basis of brachial plexus formation and its lesions. We have discussed about two important nerves. One is the axillary nerve, another one is the radial nerve. Okay, so we'll take a short break now, and after this break we'll resume back with the lesions of the other nerves and the other parts of the upper limb. Okay.